Hello again. This is chapter 28 in NURS 1202, postpartum complications. This is a nice picture. This is not a complication. All right. So postpartum maternal complications we're going to talk about. Okay. So identify, this is a continuation of theory number 5, slow number 5, as you see. Identify complications that may occur during the postpartum experience. So let's talk a little bit about postpartum hemorrhage. And let me give you some background here. It's traditionally defined as more than 500 milliliters lost after vaginal birth, more than 1,000 milliliters after C-section. Okay. Here's something interesting. It is the leading cause of maternal morbidity and mortality. It is often unrecognized until the mother has profound symptoms of shock. All right. So we have early and then we have late, as you see here. Okay. The number one reason that we have postpartum hemorrhage is uterine atony, whatever you want to say. All right. The uterus is not clamping down. All right. And we already talked about how we check the uterine fundus at the umbilicus. We start there. And then, of course, we also have what we call the 4 T's can be a problem with postpartum hemorrhage, primarily the T's of tone, which we already talked about here, the trauma we've talked about here, the tissue. There might be some retained tissue, and then the last one doesn't really have much to do with hemorrhage, but other complications of thrombus. All right. So the most common is the early. The late postpartum can happen if the uterus does not involute properly, does not go down, and that is often as a result of placental fragments. Not common, but it can happen. Here's a very graphic picture. On the letter A, you see that the uterus is contracted, it's firm. There's not a whole lot of blood coming out of it, all right? Whereas letter B, you have true uterine atony or atony, however you want to say it. The uterus is filling up with blood. It is not contracted. You see that it's very globular in shape. Not a good thing. Okay? Now, the number one thing we can do as nurses is to keep an eye on, or a hand on, if you want to say it that way. We don't literally do that, but we keep a close examination or awareness of the uterine fundus. Okay, this is how we do the uterine massage. Okay, we place one hand above the symphysis pubis, cup it, all right, cup it at the bottom there, and then we take the other hand and we massage the fundus, and we massage and gently express, or compress rather, the fundus. All right. I've seen some nurses get really, really rough, and it's excruciatingly painful. If you think about that, uterus has been contracting for maybe many hours, and it's tired, it's sore, it doesn't need any insult. So start out gently. If you have a uterus that is not responding, you may have to get a little more vigorous, but don't do it to the point that the mother is screaming and grabbing your hands. You'll need help if that happens. Have her pull her knees up if she can. That'll take some of the pull off of her abdominal wall and make it a little easier for you. Now, this is something that a nurse does not do, except maybe in advanced practice. I've only seen physicians do this. If they're really, really concerned about placental fragments or something left behind, they will put on, obviously you see this is a sterile procedure. We have a sterile gown, we have sterile gloves, we have sterile gauze wrapped around the examiner's hand that's going to be inserted in the vagina into the uterus because it's still open. It hasn't clamped down yet completely. And the other hand is firmly grasping the uterine fundus, and they will sweep inside and pull out anything that might be in there. All right. They also do this postpartum with the ring forceps and 4x4s as well. They'll do that first, and then if they continue to have problems with uterine atony, then they will go to this possibly. This is a very barbaric picture, but it can be done to help get that uterus to clamp down. Okay, they put their hand in the vagina and kind of compress the cervix and the uterine fundus. This is a last-ditch effort. We don't see this done very much. A nurse does not do this. Here is a picture of a vaginal hematoma that can actually be behind, could be the cervix, could be inside the vagina, and is protruding out. These are very, very painful. Your patient will complain of excruciating deep pelvic type pain. Also remember, we talked about the trauma. We might have a laceration that maybe we weren't aware of, or possibly should have been sutured but was not. The difference between these is your laceration, you're going to have a steady trickle of bright red blood. It's no matter, your fundus can be just as firm as it can be and midline and 1 to 2 finger breadths below the umbilicus, but you still got some trickling in. That's probably indicative of a laceration that needs to be sewn. Oftentimes your patient will complain, they'll squirm and they'll try to find a comfortable place, and it's just very excruciating pain. This hematoma, as you see here, is very painful as well, but they're going to talk about, oh, it hurts so deep inside. Oh, it's awful. Nothing I can do. No position changes make it better, that kind of thing. And what happens is if this hematoma develops, it has to be opened. It has to be drained. And that's very painful. They'll probably give her some local anesthesia there with lidocaine or something like that. Okay. Let me see if I have any more things here I want to share. All right. So this pain we've been talking about, this is part of that pain assessment. Okay. So the pain with lacerations increases with movement, or hematoma that's increasing pain, deep pelvic pain, not relieved by any position. All right. Let's see here. Let's see. Talk about the 4 T's. Later in postpartum, you saw subinvolution of the uterus, and that is often, again, relates to retained placental fragments. It can be potentially life-threatening. It's not very common, but we always have to be aware of that. The thing about postpartum hemorrhage is we need to be aware of it. We need to make sure that we understand that it's a possibility, that we never ignore a patient calling us to the room and saying, I'm bleeding a lot. That happened one time in clinical, and the patient put the light on, and the nurse answered and said, can I help you? And she said, yes, I think somebody needs to come and check me. I'm bleeding a lot. And the staff kind of, oh, yeah, she's a first-time mother. She doesn't know what she's doing. And they went down there, and she was having some significant bleeding. So never, ever dismiss your patient's complaints. You go investigate, you do your assessment, you get some information, and then based on that, make the appropriate intervention. So we're going to keep an eye on this situation very close. We're going to intervene and make sure we don't have a late sign of postpartum hemorrhage, which can be hypovolemic shock. Remember, hypo, it means low. Volemia or volemic is there's not enough volume. Okay, she's losing blood, she's losing fluids. Okay, obviously we've talked about the pathophysiology, retained placental fragments, uterine atony, trauma, right? So the clinical signs and symptoms, you need to know these signs. They're in your book, but we're going to review them briefly, but you need to read in your book. All right. Usually, initially, shock is not real obvious. It may start out as Your patient might be a little restless, and she says she just doesn't feel right, and maybe you've checked her fundus and she's a little boggy, and you massage her and everything seems to be back to where it needs to be, and you think, okay, I'll take some vital signs. Well, initially the blood pressure might be a little elevated, and the heart rate might be a little elevated because that body's trying to compensate for that losing volume, and so you're going to have a slight elevation in blood pressure, and you're going to have a higher heart rate. But as shock progresses and we do not intervene, then we are going to see a dropping blood pressure and an increasing heart rate, trying to increase cardiac output. Your pulses are going to be diminished. They're not going to be easily palpable. Your skin could be very cool, slightly moist. Your respiratory rate may be slightly increased, and then it's going to start going down. Your level of consciousness is going to change. And when you turn her over, she's laying in a pool of blood and you have missed it. So never ever dismiss the possibility of hypovolemic shock. Your interventions are, you need to get help, number one. Number two, if she's got an IV, and hope to God she does, make sure it's working properly and give her a bolus, no less than 500 milliliters. Open that thing up. It may have some Pitocin in it. Open it up. Put it on 500 milliliters an hour. She needs the fluid. She needs the pit. Check her fundus. Make sure her fundus is firm. Check her bladder. Get some help. You may end up having to give her blood or blood products. You need help managing this patient. They may have to do other things. They may have to take her to surgery and explore her uterus. There's all kinds of things. But number one, we have to support the vital signs. We have to give her the fluid back she's needing. We need to stay with her, make sure she's all right. She's going to be scared. She's going to be anxious. Do everything you can in your scope of practice to treat this. You might have just one IV. When you get some help in there, you may say, go ahead and start another large bore IV. We may need it. If you don't need it, you can take it out later. It's okay. These are things that nurses have to do. These are proactive things that you want to do before things go from bad to worse. All right? But the number one thing we need to do is we need to keep an eye on this patient, and don't let anybody tell you you're working too much, you're checking her too often. If that's what you feel you need to do, you do it. Okay, I'll get off that soapbox. We already talked about the hemorrhage. Okay, we're gonna do all those interventions. We're going to put the blood pressure cuff on her. We're going to take her vitals maybe every 5 to 10 minutes. We're going to keep checking that fundus. We're going to keep checking how much she's bleeding. We're going to, obviously, we already said we're going to get help. We're going to page the healthcare provider. We're going to have people in there helping us, and we're going to do what we need to do to save this mother, because remember, it is the leading cause of maternal morbidity and mortality is postpartum hemorrhage. Okay, so we've already talked about how we're going to apply the nursing process. Some of your nursing diagnosis may be insufficient fluid volume deficit related to recent postpartum experience, as evidenced by, and you go on from there. All right. Your outcomes would be that her bleeding would subside or stop, would minimize, and we're going to minimize the complication or take it away. We're going to do all the interventions we talked about, and as we're intervening, we're constantly evaluating. We're seeing how she's doing. We're going to make sure what we're doing is working. If it isn't, then we're going to reevaluate and maybe do something else. So it just depends on your situation, but you need help, you're going to have help, and hopefully you'll have a good outcome with your mama. One of the medicines that we use postpartum, in addition to Pitocin, is one called methyl ergonovine, or also known as Methergin. It's a very powerful uterotoxic tonic medication. It helps the uterus clamp. One of the bad things about Methergin is it can really elevate the blood pressure, and so one of the things you want to make sure you do is you take the blood pressure before you give it, and that's the answer there, obviously. Subinvolution of the uterus is another late postpartum hemorrhage possibility. The uterine involution takes longer than it should. Remember, we said by 14 days it should be back to its pre-pregnant state. Again, lots of times it can be as a result of retained placental fragments that just get missed. It happens, okay? And also a pelvic infection, which often happens after something like this. We've done a lot of vaginal exams. We've done all kinds of things. Maybe she's Group B positive, Group B, GBS positive, etc. So if we suspect retained placental fragments, then we are going to possibly go in there and do a dilation and curettage, where we go in there and we scrape the endometrium and try to get all those products of conception out. We're going to treat her with some broad spectrum antibiotics. We're going to watch those vital signs, particularly the temperature. Keep an eye on that white blood cell count. Notice if there's any bad odor to her lochia. Make sure she's eating well, that she has good nutrition that will help her. Provide for rest, all those good things that we do for patients to make them feel better. She can continue probably to see her infant and even breastfeed, depending on the extent of any infection possibly, but that would be decided on a case-by-case basis. Okay. We've already talked about this. I don't know, I think this is a double slide. I apologize, this is a duplicate. My bad. Okay. Thromboembolic disorders, clots. They don't happen very often, but they definitely can. We already talked about the etiology. Remember, pregnancy is a hypercoagulable state, and the fibrinogen and so forth may be elevated for a few days postpartum, and so that's why it can happen. Also, venous stasis. If someone's in labor a long time, they've had an epidural, they're just laying there, they're not, they obviously are not able to move their legs. That can happen. Also know that a lady who's been in the delivery area and she's been pushing, or they're expecting her delivery and her legs are up in the stirrups for a long, long time. When you take her legs out of the stirrups, be sure you lift them up and bring them down together, and very gently, because if there's any clot in there and you jolt her or you have caused some trauma, it could break loose. And there's blood vessel injury possibly as a result of C-section and so forth. Also, diabetes is also a predisposing factor. So there's a lot of things that could cause one of these clots, as we know. We have the superficial venous thrombosis. The typical signs are pain in the leg, possibly some heat, pain when walking, and so forth. We're going to give analgesics, primarily ibuprofen, maybe and Tylenol, possibly more likely ibuprofen, and maybe even they may have her take a low-dose steroid for a few days. We are going to encourage her to rest and keep her legs elevated, and we're going to put her some TED hose on, possibly some SCDs. But oftentimes, if we do the admission assessment for the risk factors for DVT, we can avoid this by going ahead and putting the elastic stockings on her and elevate the lower extremities, and maybe even possibly start some Lovenox. DVTs, again, you're going to have some pain and swelling. One leg will be bigger than the other, in the calf area particularly. It may be red, maybe hot. So there's different diagnostic things we can do. Doppler studies, maybe an MRI. We're probably going to put her on some Lovenox or possibly some heparin. We're going to, again, do all the things we did before. TED hose, elevate the legs. It's best to put the legs at the level above the heart if possible, but definitely rest and until the acute signs are limited and done. We may have to actually measure the circumference of each leg and keep track if one is getting bigger than the other. We're going to palpate that skin temperature, look at if it's edematous, check the pulses in both extremities, compare the amplitude of their pulses in each extremity, and you can, the rest of this I believe is in your book on how to use the rest of the steps of the nursing process. Pulmonary embolism is not a common thing postpartum, but is definitely something that can happen. And probably even more common would be an amniotic embolism, which is a little piece of amniotic particle breaks loose and can go into the central circulation. Same kind of thing almost, but Pulmonary embolism is obviously a clot that has broken loose in the lower extremities and has traveled through the lungs. Signs and symptoms of acute onset of shortness of breath, acute dyspnea, okay, comes on all of a sudden, acute chest pain, acute tachycardia, acute tachypnea, okay, it's going to happen all of a sudden, and it's terrifying. They look very, very scared. When you're listening to the lungs, you may hear some crackles. They may have a cough, and they may actually expectorate blood, hemoptysis. They may have some fever. Of course, the therapeutic management, of course, is we try not to let clots develop, and so we may do some of those DVT assessment risk things and go ahead and put this patient on prophylaxis to prevent clots. Again, this is not something that's very common, but when it happens, they need O2. You may have to send them to surgery for a Greenfield filter. You do supportive care with the vital signs. They may actually end up in ICU, possibly on a ventilator. Oftentimes, patients with pulmonary embolism do not survive, so it's a very significant thing. So the first three things there you see are very, very common. Not so much the abdominal pain, not so much the low-grade fever, but definitely those first three things. And so you need to get help. You need to support the vital signs. You need to give oxygen. They may need to go to the ICU and so forth. Puerperal or puerperal infections. These are infections that happen postpartum. They're not very common, thank goodness, but they do happen. You see here that the temp is above 100.4, and you think, well, that's not much, but in a postpartum woman, it is significant after the first 24 hours, and maybe even at least 2 of the first 10 days, so maybe intermittent. But the effects are, fatigue, lack of appetite, might, have trouble taking care of their baby. It can spread in the body. The whole body can become septic. It can scar the endometrial lining and cause infertility. So it's a significant thing. Risk factors, again, like diabetic mothers, also women who've had multiple gestations and placental fragment retention, things like that. Uterine atony, group B strep, positive, lots of vaginal exams, premature rupture of membranes. Those are some of your risk factors that can occur as a part of puerperal infection. Can lead to pelvic inflammatory disease and all kinds of things. Endometritis is one of those. Oftentimes with endometritis, you may have some foul-smelling lochia. You've got the elevated temperature. You may have some abdominal tenderness. Again, some of the complications can be infertility, pelvic inflammatory disease. Sometimes they say some of these things make women more prone to having an ectopic pregnancy. There's not absolute proof, but there are some strong correlations between that. The number one thing is we need to make sure we're washing our hands, we're wearing our gloves. We teach our patients the importance of infection control, that we limit the number of sterile vag exams that we do. We don't do them unless they're indicated. If we have premature rupture of membranes or we're group B, GBS positive, we're going to give the antibiotics that are appropriate. We're going to watch the fever, we're going to temperature, we're going to watch the white blood cell counts, supportive therapy. But number one is infection control measures. Have her wash her hands before she does pericare. Use the peri bottle. Don't touch the peri bottle to your perineum. When you're cleaning yourself, wipe front to back. When you put your pad on, only handle the sides and put your pad on front to back. All of those things can be helpful. Premature rupture membranes, we really can't do much about that except, again, limit the number of times people go in there and check that cervix. It doesn't need to happen unless it's very indicated. And of course, watch for any worsening signs of infection. Wound infection is probably going to be more common in your C-section patient. Occasionally it can happen from your episiotomies, your perineal infections, but not so much. Of course, your C-section incision is usually the lower part of the abdomen. and oftentimes they'll leave the dressing on for maybe 24 hours and then they take it off and leave it open to air. Is typically stapled, possibly with sutures that dissolve, but we want to check it. We want to make sure that a little bit of redness around the sutures or the staples is not uncommon. That's kind of an inflammatory response. But if it starts getting red farther out and your patient says, boy, this is really sore, and it feels hot, it looks hot, you've got some nasty drainage, your temperature is a low grade 100.4, 100.8, possibly higher. We're going to report that. We're going to maybe culture the drainage and send it off. We're going to send it for CNS. We might need to start some broad spectrum antibiotics until we get the culture report back. Encourage her to support the incision when she splint it, when she's coughing and deep breathing, because any pull on that suture line could actually cause it to open, what we call dehiscence or evisceration, but dehiscence is more common. So we want to make sure we're doing all that. Watch again, infection control measures, dressing changes as ordered. Lots of times we don't change the dressing a lot because every time we open it, we could possibly contaminate it. We're watching all those things that we would do for normal wound care. Urinary tract infections are not uncommon after for postpartum, especially if someone's had a lot of in and out CAS for urinary retention during labor. Maybe they have a periurethral tear and they're having difficulty urinating. Urinary tract infections, I think everybody knows the signs and symptoms: low grade temp, pain and burning with urination, scanty urine output, cloudy, foul smelling urine. Again, we were going to send off a urine specimen probably for CNS, urinalysis, antibiotics, local anesthetics to the lower abdomen if they're having suprapubic pain. Also other pain medicines. Encourage fluids to flush that out. Watch the urine output. Be aware of any probability of urinary retention, and do what is appropriate to manage that as well. Mastitis is most of the time not that common, but it can happen. And it's in your book, all the etiology. Lots of times milk ducts can be clogged. Sometimes the baby doesn't empty the breast properly when nursing. There's a lot of things that can happen. One of the signs and symptoms, it's usually just one breast, thankfully not both, but sometimes it can happen with both. They're very red, they're very tender, they're very hot. She may have a low grade temp. She does not want to breastfeed. It hurts. It's pretty bad. But they do still need to breastfeed if they can. And if they need to, they can pump the breasts. We may give some antibiotics. We're going to do some local measures as far as maybe putting warm towels on the breasts. That will also help let the milk come in a little bit, maybe drain that blocked duct. We can also put cabbage leaves on each breast, which will bring comfort. Good fitting bra to support the breasts. Clean the breast with just plain water, no soap. Let the breasts air dry a few times a day. Just take the bra off and the gown and just let them hang out, but they dry out, and that does help a little bit. And so they can still continue to breastfeed, but it makes it a challenge. Here's some pictures. As you can see, it's primarily the outer portion of the breast. They can actually go up into the lymph nodes in the axillary area. It can be very, very painful, as you can see. And we don't want to just breastfeed on the other side where it's not effective, because that can make that breast sore. So there's a lot of things, and sometimes you might just need to call in a lactation consultant to help with these issues, because sometimes we run out of tricks, so to speak. There's your cabbage leaves. Oftentimes they'll separate them from the head of the cabbage itself and put them in the refrigerator, and they're cool and they help a lot. Okay, I'm going to go on. So sometimes after a woman gives birth, we have some postpartum mood disorders, all right? It's not unusual for a woman to have a little bit of postpartum blues, what we call postpartum blues. That's not the same as postpartum depression, all right? Postpartum blues are not very uncommon. They can happen just because of hormone shifts. Maybe you've got a mother that's single, has little support. She feels overwhelmed taking home this new baby, and she's going to try to work, and she's having a lot of issues. And so it's not uncommon for her to have some baby blues, okay? You walk in her room and she's sitting on the side of the bed and she's crying, and you're like, what happened? And I just don't know. I just wanted to cry, and and you need to ask questions, reassure her that this is not unusual. Don't say, oh, you'll be fine. That's false reassurance. And you know what? This is not an uncommon thing that happens. Let's talk about this. What's the thing that's bothering you the most? And get some answers, get some help with her, of course. But if we don't catch this and do something with it, then it can progress into something worse, which is true postpartum depression and postpartum psychoses. And so this can be quite problematic, all right? Uh, this means that this woman she has postpartum depression, and she is not taking care of herself, and she's not taking care of her baby. She's neglecting her personal hygiene. She's not taking care of her baby. Her baby is crying. She doesn't feed the baby. She doesn't change the diapers. The house is a mess. She doesn't want to talk to anybody. She stays in bed. That's true postpartum depression. And if we can't intervene, can lead to postpartum psychoses. Oftentimes, she might just need some help. She needs somebody to come in and help her with the baby, with the housework. She may need some antidepressants. She may need some therapy. It just depends on the extent of her symptoms. So here's a little chart I found that I thought was very helpful with your differentiating between postpartum blues, depression, and psychoses. And you can look at this on your own. And here's your nursing process that you can apply, hopefully. And here's another little thing about beating the new baby blues. Okay, this is not depression. It is not full-blown depression yet, but it can definitely get there if we don't intervene. And then we can progress to postpartum psychosis, which often results in inpatient psychiatric therapy. Some families, some women have a history. Their mother had postpartum psychosis. They're more likely to have it. Again, it's not common, but it can happen. And so that's why we need to be very aware of her mood. And that's part of that bubbly. We have the bubble, and then we put the LE, with the one L is for the legs, and the other E is for the emotions. And so we're keeping track of that from that standpoint. Okay. Sometimes certain anxiety disorders will manifest themselves or be exacerbated by pregnancy and delivery. Sometimes the birth experience is perceived by the mother as very traumatic and not what she wanted. It could be that woman that comes in, I don't want any medicines, I want to have a natural childbirth, and then all of a sudden she caves in and she takes medicine or epidural, and then she has to have a C-section. All of those can be perceived and be as traumatic to your mother. And so the next time she's thinking about getting pregnant, she's like dreading it because she's worried about the next delivery experience. So she could have a little PTSD, not, again, very common. But your panic disorders and your postpartum obsessive compulsive is all a part of that postpartum psychosis, which usually, again, like I said, requires inpatient psychiatric therapy. So the bonding experience between mother and baby, I think we've talked about this quite a bit, but we definitely need to foster that and make sure that that first golden hour we talked about so much happens, if at all possible. The baby doesn't need to be whisked off to the nursery unless the baby's unstable, and maybe the NICU. But if at all possible, we want to put that baby on mama, skin to skin. Even if mother is not breastfeeding, she can hold that baby close to her and lots of times mothers will talk to the baby and look at, count all the baby's fingers and toes, and that's all a part of that bonding experience. If the daddy's in the room, we get daddy involved, or the significant other, whatever that might be, grandparents possibly. But we want to make sure that we promote that mother-baby bonding as much as we can. I know that some of you have had experiences in clinical where the mother didn't want anything to do with the child, and that's very sad. We can't force it, but we're going to try to do the interventions that we can to promote it. Make sure that we teach the family, the new mama and the family, about baby care, about how to recognize the signs and symptoms of a sick baby, how to monitor the urine output, how many wet diapers, how many soiled diapers, how to recognize if the baby's cold, and the cord care and all those things. That's our biggest role in this instance, is the teaching piece. Even a mother who's had another child, if that child is several years old and it's been many years since she may need to have a refresher course. And even a nurse, an RN, might need some help, might need some reminding about some of these things. So don't assume because a person is maybe even a physician, a nurse practitioner, an RN, or a mother of 4 already, that she knows everything she needs to know. Talk with her, find out where she's at, find out her needs, ask her, hey, is there areas of concern? Do you have some questions about maybe how to take care of the cord, because maybe her last child, we did it this way, but now we're doing it this way because of evidence-based practice. And so we want to make sure that we address those teaching needs right away. And that concludes chapter 28, I believe. Nope, there we go. Parent, infant, we talked about this. Okay. Rooming in is very good. The baby spends the majority of the time in with the mama, and the mama does the care. And usually there's a piece of paper or a clipboard or something that she writes down how many times the baby ate. If it's a bottle, how many ounces? How many wet diapers did she change? How many soiled diapers did she change? How was the baby's behavior? That would be different things. And that's a part of the teaching aspect as well, and we're going to make sure that she understands how to use that and so forth. And these are things that you can do as part of your teaching. So I'll let you read that on your own. This is important. Closely monitor parents who interact inappropriately or abusive ways with their infants. And if that's happening, you need to get the baby out of there. Even if they don't want the baby taken out, your job is to protect the child because they are totally helpless. And then you're going to get some help with maybe even security. I hope not, but social worker and discharge planner and so forth. Very, very helpful. Get your nursing supervisor involved, your physician or healthcare practitioner, whatever. You don't want to tackle this by yourself.